Okay, welcome everybody to the Shared Risk and Protective Factor peer-to-peer network. Thanks for joining today. And I'm very excited because we have two presenters today presenting on the Healthy Kids Colorado survey. So we'll dive in and get started. And then at the end of the meeting, I have some brief updates on where we're headed in terms of the future direction of the network. But today we have Christine Militao-Pele. Hopefully I got that right. I was practicing and then I got nervous. But from the Colorado School of Public Health, and Emily Fine from the Colorado Department of Public Health and Environment, who will be presenting on a supplement COVID-19 survey that we did with our Healthy Kids Colorado survey here in Colorado, which is Colorado's version of our WIRE-BSS. So I will let them get started, and we should have some time for questions and discussion following their presentation. Thank you.
Thanks so much, Colleen, for the invite to present to this group. My name's Emily Fine. I'm going to get us started here, and Christine and I will be presenting throughout. Please feel free, if you have questions, to throw them into the chat as we go. We've built in time for to address your questions at the end. We've got about 30 minutes, maybe 35 minutes of content, and then hope to have a rich discussion. So Christine, would you mind going to the next slide? Thank you. So today we are going to get into the particulars around our COVID-19 supplement that we deployed this past fall of 2020 into schools. We're going to chat through what it was like working with schools during this pandemic and data collection issues around that. We're going to frame the data as it always should be framed, through an equity lens. We're going to get into the results and findings from our fall supplement, and then we're going to also talk about how it's influencing the work going forward. Next slide. Just wanting to acknowledge the teams that work on Healthy Kids Colorado survey and SmartSource. So at the State Health Department, we have Allie, myself, and Jackie, who's our data analyst who focuses on regional and statewide data. Next slide. Christine's team. This is the team that made our data collection during the pandemic possible. So just wanting to give a quick shout out to Ashley, Christine, Ming, Sophie, Whitney, Hannah, Lauren, and Alicia for their work on this. Next slide. So let's get into the particulars. First of all, Healthy Kids Colorado survey, as Colleen mentioned, is Colorado's version of the Youth Risk Behavior Survey. Colorado has participated in the Youth Risk Behavior Survey since its inception in 1991. And around 2012, 2013, we really expanded our efforts in Colorado and created a more robust sample that we call Healthy Kids Colorado Survey. And we actually have statewide and regional representative data. Also, schools get their data back. And so that's kind of a distinction between WIRE-BS and Healthy Kids, is schools get a bunch of reports back from our team at the School of Public Health. So typically we administer in the fall of odd-numbered years, and the State Health Department contracts with Christine's team at the School of Public Health to really administer the survey in schools, be that kind of local connector. And then the State Health Department really focuses on those regional and statewide results to really add a layer of anonymity to the students and schools participating. So I help coordinate a steering committee made up of different state departments. So there's representation from CDPHE, there's representation from the Department of Public Safety, the Department of Education, and our Office of Behavioral Health. And the steering committee really helps guide all major decisions related to the survey. We also have an advisory committee, including school staff, local public health, and community organizations. And just like the WIRE-BS, the Healthy Kids Colorado survey is a voluntary and anonymous student level survey. Just to give you an idea of some numbers, in 2019, we surveyed more than 100,000 students and administered in over 50 public middle and high schools across Colorado, so that you can just see that the effort is much larger than the YRBS, which is administered in 40 schools in a handful of classrooms. Next slide, please. So the purpose of our 2020 Healthy Kids supplement related to COVID-19 was really multifaceted. We really wanted to evaluate the effect of the pandemic on youth mental health and risk factors using the school's fall 2019 Healthy Kids data as the comparison. It was also a really fabulous opportunity for us to pilot new questions and move to a 100% online administration for the survey. Next slide, please. Our timeline was pretty fast and furious. In August and through early September, we finalized the instrument and secured all of the approvals needed to survey youth in schools, including IRB and EDAC, which is our Education Data Advisory Committee, run through our Department of Education. In September, Christine's team really did school outreach and invited all 2019 participants to participate in the supplement, and really got our enrollment numbers in the survey up and running. So in October and November, it was administered. Again, this is just in the fall of 2020, and then we were able to get reports back to schools in December and January. Next slide, please. Christine's going to talk through kind of what it was like working with schools during this time.
Thanks, Emily. Can you all hear me okay? So as you can imagine, administering a survey during a pandemic was not the easiest, and it was filled with lots of challenges, but actually some unexpected successes that I just want to begin with as kind of context before digging into our actual results. So last fall, as we all know, schools were navigating a ton, not just the pandemic, but also let's not forget about the wildfires that were plaguing our North Central and mountain regions. And schools just having shifting schedules, sometimes on a week-to-week basis, depending on cases, whether they were having to quarantine fully or just by classrooms. So it was a lot, and we wanted to be really sensitive of all of those barriers while trying to get the survey out in the field. A few other somewhat unexpected challenges that we had were districts wanting to do their own survey. And we're always fans of data collection at a local level, so wanted to be in support of this, and just backed out of those communities that were already getting on top of data collection, just knowing the very unique circumstances that we were navigating in the fall. We also needed to time our survey window in such a way that we could get data back to schools within the fall. So because of that, like Emily shared, really October was a prime time to be doing the survey. It also coincided with something called the October count, which for those of you who may not be familiar, this is when schools submit their official enrollment, and it informs funding for that school, and it's really important. So we just tried to be sensitive and coordinate with schools so they weren't having too much to do at one time. And then of course, our heroes, the teachers, not wanting to be yet another burden to them during this incredibly challenging time. So to make sure that schools that were able to do the supplement were only at capacity, had the capacity to do so. And we just tried to make it really easy for teachers who were serving as our survey coordinators. And some of those examples were the successes that came out of the supplement. So we pivoted to an exclusively online platform, not just for the survey, but also for all of our technical assistance. So registration forms, materials, and we got a lot of positive feedback from schools about this, and we'll be implementing it moving forward in our 2021 administration. We allowed schools to have a little bit more flexibility with when they surveyed. Historically, for Healthy Kids, we tried to have schools survey on a single day, maybe two at most. But knowing the synchronous, asynchronous scheduling shift, we expanded it to actually up to 2 weeks for schools to make sure that they got as many students participating in the survey as possible. And then I'll just share that last point. Because we had a shorter window, we were able to turn around reports really in an unprecedented window, just getting it back in the same semester, to make sure that schools had this data to move forward with decision making. All right, I'm going to give it back to Emily to talk about framing our data.
Thanks, Christine. Before we get into the supplement results, I really want to ground us, add some context, and give some credit. For this part, I collaborated with my colleague at CDPHE, Sasha Mintz, who has presented to this group before. Sasha continues to receive national recognition for centering equity in her work with the statewide child fatality prevention system. This fall, Sasha and the team published a report called "The Role of Policies and Systems in Child Deaths in Colorado" that I recommend checking out, especially for the literature citations. I'll throw this link into the chat once we're finished, in case you need a reminder for where it lives. So first, let's start with some terminology to get us all on the same page. Inequities are systemic, avoidable, and unjust factors that prevent people from reaching their highest levels of health, while disparities are the differences in health outcomes between people related to social factors such as race, ethnicity, gender, sexual orientation, or geographic region in which where one lives. So measuring disparities really helps us measure progress towards achieving equity. Next slide, please. We know that generations of social, economic, and environmental inequities result in Colorado youth experiencing negative health outcomes and have a greater impact than individual choices. When interpreting data, one must never lose sight of these systemic, avoidable, and unjust factors. These factors perpetuate the disparities observed in youth health measures. Further, knowing that limitations exist in all of our surveillance systems, we have a responsibility to pair data with more context and research about how inequities impact youth so as not to perpetuate harmful stereotypes. Next slide, please. So let's talk about some of the well-documented examples of these systemic, avoidable, and unjust factors that perpetuate disparities we see in youth health data. This is not an exhaustive list, just some examples to help frame the data that Christine's about to share. So the majority of youth who participated in the supplement were from rural areas. 73% of Colorado's counties are designated as rural or frontier, according to designations set by the Colorado Rural Health Center. Youth in rural areas may experience social isolation and decreased connectedness, that super protective factor that we're all trying to affect since it's so protective against multiple adverse health outcomes. They may experience loneliness and depression. It's well documented that Colorado's rural areas experience a shortage of mental health care professionals and behavioral health care services and long EMS response times. Stigma and social norms may prevent youth from seeking help for mental health concerns. Racial and ethnic disparities in youth health result from the conditions facilitated by racism and discrimination. Our Indigenous youth in Colorado may experience historical trauma from the violent colonization of their lands and modern prejudice with the pervasive use of Native American school mascots. Youth of color may also experience poor mental health and chronic stress and increased substance use, which may be a coping mechanism for high levels of stress endured from everyday experiences of racism. Racial segregation driven by redlining has concentrated poverty areas in Colorado and isolated youth from key resources like healthy foods and healthcare. Heterosexism and transphobia dominate our systems and culture. Heterosexism and transphobia create a social context where LGBTQ+ youth often experience discrimination, stigma, harassment, and bias, including rejection from friends, family, and community, limited access to LGBTQ-informed healthcare, and non-inclusive school curricula and anti-harassment policies. In order to reduce the disparities we observe in Healthy Kids Colorado survey results, we must focus our prevention efforts on the systems and policies that create and perpetuate these inequities here in Colorado. And with that, Christine's going to get more into the supplement design and results.
Thank you, Emily. So let's start with a description of who participated. So we had all in all 73 schools participate in our supplement, 43 high schools and 30 middle schools. But today we're actually just focusing in on 26 high schools and 25 middle schools that had a higher response rate, knowing that their data is going to be a little bit higher quality. So that's the results shown today is for that cohort. For those of you interested who want to see more, today will really just be a sampling of some of our supplement findings, but we do have a cohort report that includes results for all indicators that were asked and by all stratifications available. So our supplement cohort was predominantly rural. We found that schools that were a part of smaller districts were just able to get up and running with the supplement quicker. And so schools coming from a rural setting, but then also districts being a little bit smaller in size, which you can see in that last point. And then for free and reduced price lunch, which is a common proxy for community socioeconomic status, we had schools fall between 50 and 75%, which is kind of moderate to high. A few disclaimers and limitations on our supplement participants. This cohort is in no way representative of the entire state or even of the Front Range. It's substantially smaller than our full statewide sample, which is closer to 250 schools. And we didn't do any random sampling. We really were pulling a convenient sample from those schools that had participated in 2019, just so we could get that pre and post kind of cohort study design for the supplement. We are not showing any findings kind of by intersectionality where we're stratifying by 2 levels. That's certainly available for analysis, but just for today to try and keep things simple, we're not getting into that. And we're in the process of releasing these results kind of on a continual basis. What's kind of coming around the corner is a brief focused on racial equity that includes findings from 2019 and also the supplement. So if you're interested in seeing that, please reach out. All right, the instrument itself was significantly shorter than our standard survey that we do in odd numbered years with just 53 questions. We had the same questions for middle and high school and wanted it to be done in 30 minutes or less, just so that burden was as light as possible. We used Qualtrics as our survey platform, which is typical of previous years. And from the 2019 instrument, we kept a good number of questions on just for consistency in these domains, spanning bullying through substance use all the way through school connectedness, but also wanted to use the supplement as a chance to pilot new questions, some that were incredibly timely for the pandemic. So getting a sense of where students were while taking the survey, experiences with racism, experiences with COVID-19, and a few new questions on protective factors that I'll show here in a little bit. We also piloted new ways of asking certain demographic questions around race, ethnicity, sexual orientation, and gender identity. Okay, so what we were most excited to look at was how that cohort of schools who had results from 2019 compared to 2020 as sort of a pre compared to during COVID cross-section. So I'm going to walk through this overview table. And just for some conventions, I'll have indicators listed on the left in domains, and then looking at whether there was a significant change among high school students in the first column or middle school students in the second column. I'll use a convention of green text to show a positive change where risk factors are decreasing or protective factors are increasing, and then vice versa for a negative change in red text. All right, so for our indicators around mental health, for depression or feeling sad or hopeless for 2 or more weeks, we saw no change among our high school students and middle school students. We have 3 questions around suicide ideation that kind of increase in severity from considering suicide all the way to attempting suicide. And we actually saw a significant decrease in these indicators among our cohort sample. I want to pause here and say that these findings we know are not necessarily consistent with the story at large around the suicide crisis among young people. And we know that this snapshot is particular to a single point in time and for a small group of communities. And it was pretty early in the fall, so we feel that they were just navigating potentially different circumstances at that time, but in no way want to take away from the crisis that we know is plaguing many, many communities around the state at this time. For substance use, we ask about current use or past 30-day use, and also ease of access for marijuana, vaping, cigarettes, alcohol, and prescription drugs. And these are all their own individual questions, but for the purposes of this table, I'm kind of grouping them together here. So for current use, across all those substances for high school students, we saw a significant decrease. And for middle school students, that same decrease for vaping and for marijuana, but no change for cigarette use and alcohol use. For ease of access, same significant decrease for high school students across the board, knowing that those two things are really linked, ease of access and current use. And then among middle school students, just a decrease for cigarettes, alcohol, and marijuana. Our last domain here, we've grouped together indicators tied to home life and school connectedness, the first of which being experiences with hunger. And we saw among our high school students, there was a significant decrease for this. For our middle school students, you'll see NA here for a few of these questions, and that's because we didn't ask the same question in 2019, so we don't have a comparison to look at. For screen time, we saw a significant increase. And while I have this in red text as kind of a negative finding, just because of the implications for reduced physical activity, we know that everyone, including ourselves, had increased screen time, probably still has increased screen time as kind of the new norm for navigating the pandemic. And in some cases, it was absolutely necessary. So just framing it with kind of that grace. For these next two indicators, thinking school is important and that courses are interesting, we did not see a change for thinking school is important for high school students, but we did see a significant decrease in thinking courses are interesting. Did not have that question for middle school students. No change for electronic bullying for high school students, and also for sleeping somewhere other than their home, which is an indicator around housing security or stability. But we did see a significant decrease among our middle school students. So I know there's a lot here, just kind of an overview on some of the trends that at least we thought were more interesting and compelling. But again, should you want to see more, we do have a full report. Okay, we're now going to start showing some of our findings by stratifications to really try and elevate disparities that we see in our supplement data, but that we know are consistent with every Healthy Kids administration, unfortunately. So these findings are not necessarily unique to 2020, but we want to continue to identify them and name them as they speak to those inequities that Emily framed us in earlier. So this slide, we're looking at our 4 mental health indicators. So our proxy for depression, feeling sad or hopeless for 2 or more weeks, and then those 3 suicide ideation questions. Considering suicide, making a plan for suicide, and attempting suicide 1 or more times in the past 12 months. We're looking at gender identity with our cisgender students being represented by a purple bar and our transgender students being represented by the green bar. So right away, you can see a huge disparity wherein our transgender students are facing disproportionately high prevalences of these negative mental health outcomes. If I go to the next slide, we can see kind of the same trend for our LGB students, which we have in a dark green bar, as compared to straight students in the light green bar. All right, for this next section, I'm going to show our 2020 data by school learning environment. So we know that this was another dimension to the pandemic, was students being fully in person in some schools, having kind of a hybrid learning environment where they spent some time in school, but some time at home, and then an exclusively virtual or fully remote learning environment where they were either at home or in another location that was not their standard school building. So I'm going to do another overview table here. The 2 columns are now showing the hybrid learning environment as compared to in-person, and then the virtual learning environment as compared to in-person. So for mental health, we did not see any difference by learning environment for depression or for suicide ideation. For these 2 new questions that were unique to 2020, we asked about stress. And we did see that our hybrid and virtual students reported higher levels of feeling more stressed during COVID than their in-person peers. Kind of on the flip side, related, they had lower rates of managing stress, or reported rates of managing their stress. For substance use, we did not see a significant difference between our hybrid and in-person students, but we did see for our virtual students lower rates of alcohol consumption, with no significance for the other substances. For ease of access, our hybrid students had higher rates than in-person peers, and our virtual students had lower access to e-cigarettes than their in-person peers. This next section for home life and school connectedness, we somewhat surprisingly didn't see a difference in non-school screen time across learning environments, but we did see our hybrid and virtual students thinking school was much harder than their in-person peers and having worse outcomes around thinking school is important and that their courses are interesting compared to in-person. No difference for electronic bullying. And this next indicator was unique to 2020, and it was 2 questions around abuse, physical abuse and emotional abuse, really trying to get at some of those adverse childhood experiences. So no significant difference for hybrid students, but for students that were fully virtual or always at home or away from school, they reported higher rates of emotional abuse than their in-person peers. And then our questions around COVID-19 safety practices that were, of course, unique to 2020. We asked about mask wearing and hand washing. And across the board, we saw higher rates of these behaviors among our hybrid and virtual students than students that were fully in person. So we have speculations as to the why behind some of these observations, but unfortunately, with Healthy Kids being a cross-sectional data source, we can't really get to the why, but we of course have some ideas. So I'll stop with that. I've been talking a lot about questions that were new to 2020. This just shows kind of fully where they fell in domains. So we had experiences with racism, which I'm going to get into here in a few slides. New ways of asking about race, ethnicity, sexual orientation, and gender identity. Of course, experiences with COVID-19. And then some new protective factors around school belongingness and neighborhood safety. So for those, some of the new risk and protective factors, we wanted to see if some of those same trends or disparities that we noted in other types of indicators also were consistent here. And we did see that to be true. So for risk factors around experiencing increased stress during COVID, or feeling worried about family and friends during COVID, we just saw higher rates of these among our lesbian, gay, and bisexual students as compared to their straight peers, transgender students having a greater burden than cisgender students, and actually females having higher rates than males. And then everything is reversed for protective factors. So showing that those same disparities, but just the flip side around stress management and recovery. So we were asking these same questions for our 2021 statewide survey, and we'll be looking similarly at these stratifications to see if those disparities exist within a larger, more representative sample as well. Okay, our questions on experiences with racism and discrimination. There were 4 of them. You can see them along the x-axis, specifically asking if the student saw their family being treated unfairly because of the color of their skin, language, accent, country, or culture. If they felt people assumed they were less intelligent because of their race or ethnicity during their lifetime. If they were treated unfairly because of their race or ethnicity, or if they were watched or followed because of their race or ethnicity. You can see our different racial ethnic categories in the legend below: white students in dark green, Hispanic light green, Black and yellow, Asian as light blue, American Indian, Alaska Native as purple, and multiracial as dark blue. So right away we see disparities among our Black students, Hispanic students, multiracial, AIAN, and our Asian students as compared to white students, and in some instances, the total aggregate. So we knew that these questions, that these indicators were going to be a more direct measure of experiences with racism as opposed to what's historically been done, which is using race as a proxy for that. So we're really trying to move away and get closer to direct measures of racism and discrimination as we know them to have severe and very negative impacts on the health and well-being of our young people. We're going to continue asking these questions, just slightly changed to be during the past 12 months as opposed to lifetime for 2021. All right, so I think we're almost here at the end, but I wanted to show the two new protective factors around school belongingness and neighborhood safety by gender identity and then by sexual orientation. So as these are protective factors, we're seeing those same disparities just flipped, wherein our transgender students are reporting lower rates of both of these protective factors than their cisgender peers. And then by our various race ethnicity categories, we're also seeing those disparities among our students of color. So specifically Black students, Hispanic, AIAN, and multiracial especially. Okay, I'm going to turn it back to Emily to wrap us up and talk about data into action.
Thanks, Christine. You can go to the next slide. So we already know that schools started using their data as soon as they got it back to really understand how young people were navigating the pandemic, if schools needed to create more supports within the same school year. Schools were pairing their supplement results with their 2019 results to really help inform any adjustments to their school health improvement plans. They also used it for grant applications for more prevention funding. And from the state's perspective, our teams are leveraging feedback from youth, schools, and communities to really make our survey instrument better. Knowing that Colorado youth are not a monolith, we're asking about race and ethnicity, sexual orientation, gender identities, and disabilities in more expansive ways to really better reflect our population so that we can all create culturally responsive and specific prevention efforts. And we will continue to include youth in our processes and pair data with stories from youth to really further understand their experiences. So that is kind of the end of our presentation. So we'd be happy to open it up for any Q&A.
Thank you so much, Emily and Christine. Are there any specific questions that people have? I have one to kick us off, and then you kind of addressed this in your last slide, but I was curious and talked about schools using the data, but I was curious if you knew of any like state programs or state agencies or like local public health that have used this data for programmatic decision making yet, or plans to.
It's we definitely recommend use at the local level, only because this is a very small smattering of schools that participated, and so definitely encourage schools and communities to use their school level reports. It's a little different than what the state does with our typical full year administration Healthy Kids results with regional and statewide data. And so we do know that schools individually use their data to apply for new grants and more funding and all of that. But yeah, it's we don't have those stories about regional and statewide use because it's not representative.
That makes sense. I guess another question that I have is knowing that we're still in the pandemic, and I know this is a COVID-19 supplemental. It sounds like you're using some of the questions that were piloted for your 2021 survey collection. Do you anticipate doing any other supplementals or seeing if you could compare to like last year's if there's changes over time?
Yeah, we actually incorporated a lot of the COVID-19 supplement questions, like specific to COVID-19, into our full 2021 tool. And so we'll actually have the representative comparative data between 2019 pre-pandemic and taken in the fall of 2021, currently in the pandemic. We'll have a much more robust sample. And so we're looking forward to kind of seeing the full effects of how youth are answering those questions with the more robust sample.
Thanks, that's helpful to hear. Are there other questions from others in the group? Feel free to put in the chat or to come off mute. Not seeing any or hearing any, which is okay. I know that Em also did put the report that she mentioned in the chat. So it's the role of policies and systems in child deaths in Colorado. So definitely worth checking out. And also her email if you have follow-up questions. So thank you so much. Yeah, thanks so much, Em and Christine. Really appreciate you taking the time today to present, and kind of looking forward to seeing where this work grows in the full data collection process this fall as well.
Thank you for having us. Really appreciate it.
And then I just wanted to quickly share some of our plans for the future of the peer-to-peer network. So we are going to be partnering with Safe States Alliance and Health Management Associates over the next year or two to co-lead and facilitate the peer-to-peer network due to some staffing changes over at our state health department, and because of Safe States and HMA really entering into the shared risk and protective factor space since we applied for this peer-to-peer network. We just wanted to make sure that we connected with them and leveraged opportunities and learning that they are also doing. So more to come on what that partnership is going to look like. But since the network has been in existence for a couple of years and some of our plans got upended a little bit because of COVID, we had all these intentions to do in-person site visits and have our in-person annual meeting, but due to COVID, we weren't able to follow through on that. We're just trying to figure out the future direction of the peer-to-peer network over the next 2 years. So one of the things I anticipate happening is Safe States and HMA leading a needs assessment process with members of the group just to check in on where we would like the network to go and what needs members have so that we can address those. And then we will continue to have an annual meeting in conjunction with Colorado's Shared Risk and Protective Factor annual conference. But the in-between learning opportunities and training and technical assistance that will be provided is to be determined. So look forward for more information from us here at CDPHE about that, and we will, we're excited to see where the work goes. Are there any final thoughts or questions that folks have before we end the meeting? Okay, if not, thank you so much for being here today. And thank you again to Emily and Christine for your presentation. We'll talk soon. Bye.